Thank you, Dr. Bianchi. So hello, everyone. I'm Ruth Warre from ITSE, and I'm very excited to be here today. So Dr. Arjumand Siddiqi, who is with the University of Toronto and the Hospital for Sick Children in Toronto in Canada. So Dr. Siddiqi will be speaking about the social determinants of health and COVID-19 research with children and adolescents in Canada and the US. Over to you, Dr. Siddiqi.
Thank you so much, Dr. Ware, for that kind introduction, and to Dr. Chambers, Dr. Bianchi, the whole team. And I will be remiss if I don't thank Joanne 1,000 times for all her work and all her patience with me. So I'm just going to share my slides. And as I do, just tell you what a pleasure it is to be with you. And this is such a terrific session to have, so useful. So I want to talk a little bit today about what I see as some key lessons that might be useful to keep in mind for both Canada and the US. And these sort of come from both the COVID era, but also the COVID era in the backdrop of what we've been learning over time about social determinants of health. And I just put up a set of papers that we've been working on US-Canada comparisons over time. So we've been trying to understand why it is that Canada and the US have different health profiles. And so we've looked at overall health, population health. We've also looked at a host of health inequalities. And the kind of impetus, the motivation for doing this Canada-US comparison comes from the political economy literature, where what we've learned is that you can actually see a pattern across the kind of high income countries of the world, the sort of long-standing, arguably democratic, arguably high income countries. And if you look at that first left-hand column, the categorizations of these countries has been done in terms of how they essentially distribute social determinants of health, how they distribute income, what kinds of policies they have to give people resources and services, what is the kind of mechanisms they use for that. And I'll just point your attention to the liberal column, which is that next column. And in that column is the United States and the United Kingdom, and incidentally also Canada. And the idea is that compared to other high-income nations, both the US and Canada tend to have a lot of privatization of goods and services, meaning the government doesn't often provide them as a basic right. They often have kinds of need-based thresholds for obtaining those things. Benefits tend to be flat and actually tend to be less generous than in many other high-income countries. And so the US and Canada are at once sort of in the same boat in relation to other countries, but also have significant differences. And of course, healthcare is sort of the most obvious, whereby Canada has a universal system. In the US, more healthcare is privatized and so on. So that's the kind of backdrop. We sort of see that Canada and the US make a useful comparison, and we see that not only for health, but also for fields that study social determinants of health. And I think there are sort of 5 lessons that we've learned in kind of situating the Canada-US comparison in this context. And the first is rather a strong statement, which is that, in effect, overall population health and health inequities are the same thing. I'll turn your attention to the left-hand graph, which is a graph that depicts the trajectory of life expectancy in Canada and the US. And the most notable thing is actually on the far left-hand side of the graph, which is that in about 1950, a gap opened up in life expectancy between Canada and the US. It closed somewhat right after the 70s, but since then it really has maintained itself. And so Canada has had at least a 2-year lead in life expectancy over the US for many, many decades. And at the same time, what we've observed on the right-hand side as an example is that the two countries are very different in terms of the extent of their health inequalities. And so this is a graph that depicts income-based inequalities in the proportion of obesity in the two countries. And you can see that in the US, there are both higher rates of obesity, but also a steeper gradient across income groups. less steep in Canada and lower proportions as well. And so one of the things we sort of have observed is that there is both this phenomenon of better overall population health and less inequality in Canada, though not none by any stretch of anyone's imagination. And in some ways, that's not surprising. And as I say, these two things are very associated. This is a framework that may be familiar to many of you. It's the World Health Organization's framework on social determinants of health. But I would argue this is actually just a framework of health, of population health. And so what this framework essentially tells us, working from right to left, is that health is a function of a variety of mechanisms: biological, behavioral, psychological, environmental, and so on. And that those mechanisms are effectively dictated. Your exposure to those mechanisms is dictated by your social conditions, your social determinants of health. And that is essentially set up by the kinds of policies and other societal conditions we have in societies. And so on the one hand, yes, this is about social determinants of health and about health inequities, because what we find is that, of course, our social conditions very much dictate what kinds of behaviors and biological factors and psychological factors to which we're exposed. But on the other hand, this then says all health works like this. And so on the one hand, when we try to separate out what is health inequity from overall health, I think we do a disservice to the fact that these things are very tightly coupled. The second lesson is that there really is no substitute for addressing the fundamental causes of health inequities and population health, which are the social determinants. This is just a quick slide to show you examples of health inequities that have been documented in both countries. And it's all just to say that we see health inequities in almost every outcome of which we know for children and for adults. And again, not very surprising, because this is kind of caked into how population health works. And this is a slide that says, once again, with COVID, we saw the same thing. So unsurprisingly, COVID was another outcome in which health inequities emerged. On the left, top left, is racial inequalities in COVID for children in the United States. We don't have similar data in Canada, but we do have, for example, for the city of Toronto, overall all population racial health inequalities in that bottom right-hand graph. And just the way to read that graph is that the gray bars are the proportion of people with COVID. The green bars are their proportion in the population. So you can see that on the left-hand side for the Middle Eastern population, for the Black population, Latin American, South Asian, almost every non-white group is overrepresented in Canada, much the same as you saw in the United States. So effectively, the message is that because we've never really addressed the social determinants, and in fact, they tend to be getting worse over time, here again, COVID is another outcome in which we see health inequities. And so framing it in the broader scheme of things is very helpful. This is a graph from Toronto Public Health Agency where they tracked health inequalities over time between 2005 and 2015, and in fact, implemented programs to help inequalities, educational programs, and so on. And yet they found that things got worse over time, despite a concerted effort to address them. And we think that's because the social determinants of health got worse over this time. This is when median incomes declined, when precarious employment got worse, and so on. And so it was almost like no matter what Toronto Public Health did, what kind of programming they implemented, it couldn't make up for the fact that the upstream social determinants were getting worse. So you can see that here, that in the sort of right-hand side of the column where it says material circumstances, behaviors, and so on, that's kind of where Toronto Public Health intervened. That's where we often intervene on social determinants of health, but it's really the upstream stuff, the root causes that need intervening. Otherwise, you see that social determinants will continue to assert themselves through different mechanisms to different outcomes, and that's COVID. So we didn't really address the social determinants. A new mechanism and a new disease came up, and lo and behold, we saw inequities in that condition as well. The third lesson is about routine monitoring of child health inequalities and adult ones as well, for that matter, to understand how and whether they react to societal changes. So I often hear a very valid critique, which is that we often measure inequities and don't do much about them. I think my pitch is not to throw the baby out with the bathwater. And I was very struck with this graphic from Public Health Ontario that tracked not inequities, but rates of COVID in different age groups over time. And those are the kinds of lines that you see, different age groups, and their number of tests in this case over time. And superimposed on that, you can see that they've marked certain key moments where societal conditions changed, where schools opened, where they closed, where screening criteria were updated, and so on. And it's very useful to think about how actions that we take in society can affect inequities amongst children, and again, amongst the population in general. And we have quite a bit of data that would enable us to do monitoring work of that nature. I think the US has, quite frankly, better and more accessible data in this regard. This is from a study where they looked at differences across time during the COVID era in cases of COVID by the proportion of crowded housing in the area that you live in. So instead of a basic socioeconomic indicator, they took crowded housing, which was a bit more relevant for COVID at the time. But the point being that we can find socioeconomic indicators that give us good information, good monitoring information over time, and then we can see whether inequalities are changing when we implement different interventions. The fourth lesson is that community-based research is absolutely critical here. This is sort of a message to my Canadian colleagues, but so is the fundamental science of inequity. I think we can see from the framework that there are many reasons that community-based work is absolutely critical. It's how we can know, as Dr. Bianchi put it in her opening remarks, what people's lived experiences are. It's how we know what they are faced with from the upstream factors. But at the same time, I think there is a strong case to be made that we need very strong social and health science on how these mechanisms work. And those things don't have to be distinct, but it is the case that I think we need to be very mindful of keeping both fundamental science and more applied community-based work going. And the final lesson for me is kind of a thorny one, which is that I think we need to understand the sociopolitics of the child health and child inequity landscape. This is just a sort of potpourri of different charged headlines that we saw over time. People who fell on different sides of the COVID issue. There were sort of different coalitions formed about what we should do about COVID in kids. People were sort of wondering whether it was okay to be closing schools when the kids who are harmed the most are the ones who already face grave inequities. On the other hand, people were saying, but those are precisely the kids that face a lot of risk of COVID, and their families face a lot of risk of COVID, and so on. And I think my objective here is not so much to adjudicate who is right or wrong in this, but just to say that I think this was a big part of the landscape of how we intervened on children, how we thought about what interventions should be, and that we need to understand these processes, these dialogues, these discourses, these coalitions more than I think we do or did going into COVID. So I'll leave it at that and at the 5 lessons that I think at least I took from this era. Thanks very much.
Thank you so much, Dr. Siddiqi, on that very thought-provoking keynote address, and for taking on the challenge of comparing the health equity issues in the US and in Canada. We appreciate that. My name is Dr. Vesna Kutlesic. I'm the Director of the Office of Global Health at NICHD, and my colleague, Dr. Janelle Walker, has kindly offered to track our Q&A box here with questions coming in from our audience. So if you have some questions for our keynote speaker, please put them forward at this time. And I think that right now, we are still waiting for people to send things in. So I prepared some questions myself. So I'm going to ask a question here while we're waiting for others to send theirs forward. So Arjumand, based on existing research, what would you say are the priorities or next steps for addressing fundamental health equities in Canada and the US? And would you say that this is similar or different in our two countries?
Yeah, it's a great question, Vesna, and a difficult one, I must admit. I think probably one thing we have to understand is that it will take cross-sectoral action. And so I think a big emphasis that's really worthwhile is trying to understand how to intervene on those upstream factors in some structural way. That's not an easy thing to do because most of those conditions don't move when we produce evidence that says they should move. They're deeply political. And so I think we have to not shy away from those kinds of processes and problems in understanding what to do about inequity. I'm thinking even about some research from Scandinavia, in which they established a body that was sort of responsible for looking at how social policies will affect kids, even when on their face, they're not policies about kids. So when labor policies change, when trade policies change, when healthcare policies change, how will those policies impact kids? And so that body was sort of integrated into the government in order to sort of represent the needs of kids, and particularly vulnerable kids. So I think things like that will probably be the best sort of bang for our buck if we really want to eliminate health inequalities.
Terrific. Thank you for that answer. Would you say that the fact that Canada has a national health system that differs from more the privatization within the US impacts the health equity issue in a substantial way?
I do. I think it impacts it in two ways. One, that I think there's no question that having access to healthcare makes kids healthier, particularly kids who have illnesses of one sort or another. I think their outcomes are better when they have ready access. At the same time, what we've learned from the population health literature is that if you look at large population trends, they are not primarily driven by healthcare, because they are primarily driven by the factors that make you sick in the first place. And that tends to be in the realm of social determinants. It tends to be about the resources and experiences of everyday life that you're faced with. And I think that's primarily why we see inequities. It's because across racial groups, across income groups, our access to resources, our experiences of everyday life, our ability to live sort of stress-free, comfortable lives is really different. It's shamefully different.
Thank you very much for that answer. I noticed that some questions have come in through the Q&A. So would it be possible to please speak to long COVID in adults and children from a health equities and social determinants health lens? So they're asking specifically about long COVID.
Yeah, so I'm not a long COVID expert, but let me give you what I think the primary inequity issue is, at least from a sort of just describing it perspective. I think there are three issues that will probably emerge. just as I mentioned at the outset, inequities are unfortunately the default way that health is organized. And so it would be surprising if long COVID did not demonstrate inequities over time. And I think we already have some evidence of that. So I think we need to anticipate inequity rather than be surprised and react to it after the fact. So that's one thing. The second thing is I have a hunch, or at least a question in mind for the people who can study this stuff. And that is that it may operate very much the same as we see infant mortality and maternal mortality operating, which is that when your body is already physiologically compromised from chronic stress, faced mostly or very disproportionately by people who have who face a lot of disadvantage, then additional health insults, additional crosses to bear, so to speak, in health terms, become more difficult. And so I think long COVID not only will be more common in more disadvantaged people because of social determinants they face in real time, but because of the sort of life course perspective coming into COVID and what they've already faced throughout their lives. So long COVID becomes even more difficult. And then the final sort of point is that then you have healthcare access differences. So management of long COVID becomes very difficult for people who have less access to care, particularly less access to specialty care, ancillary care, and so on.
Excellent. Thank you so much for those very helpful insights. We need to conclude now this session, and we'll be transitioning to our next panel. I think we have at least another question in the Q&A. So Arjumand, if you can perhaps reply to folks on your off time, during the webinar, we'd appreciate it. Thank you.
Thank you so much.
Thank you.